Today you're listening to PSGR. My name's Jodie Brunning, and I'm talking to David Bell. We're talking with context around New Zealand's proposed gene technology bill. What that bill does is it writes out many organisms because the government has stated that they are indistinguishable from naturally bred organisms. That then pushes the regulator to actually completely dismiss and ignore that class. That regulator would not be responsible for reassessing whether those so-called indistinguishable from naturally bred organisms would impose risks, including, for example, heritability and risks to off-target and non-target organisms. What that legislation also includes is a mandatory medical authorization, whereby if two other regulators globally turn around and approve a gene-edited, gene biotechnology drug or vaccine, we would automatically be obligated to accept that as well. So this sets in place a whole raft of concerns and queries that we could sort of answer. So David is a public health physician and biotechnology consultant in global health. And David is a former medical officer and a scientist at the World Health Organization, the WHO, program head for malaria and febrile diseases at the Foundation for Innovative New Diagnostics, FIND in Geneva, Switzerland, and Director of Global Health Technologies at Intellectual Ventures Global Good Fund in Bellevue, USA. And David has a position currently as co-lead of the University of Leeds REPPARE project on pandemics and is a senior scholar at Brownstone Institute. So thank you, David, for joining us today. Could you start with talking about your work in the biotechnology sector and the recent changes over the last 5 years where the smaller organizations, let's call them the fish, seem to be declining in favor of the whales, and what that might be doing in the sort of the global world of infectious disease management and how biotechnology intercepts with all of that, please?
Yeah, I think the changes go back a bit further, but there's two major areas of change. I think one, which has affected a lot of the work that I do, sort of high burden diseases in low middle income countries, sort of malaria, schistosomiasis, other diseases that people don't hear of much, but kill a few 100,000 people every year. And before COVID, there was quite a large interest in addressing these. They're often called neglected tropical diseases for various reasons, but there were angel investors and people who wanted to put in some money to do good, who would fund new technologies directed at these, not on the basis that they'll make lots of money, because there's not much money in diseases of poor people, but on the basis that they would get some return in feeling they've done good for humanity. This changed a lot during COVID. I mean, partly because the economy's gone down, but partly because a lot of people made money very quickly in biotech. They managed to produce very poor quality diagnostics, for instance, and obviously the vaccines, genetic vaccines, and they made a lot of money very quickly. And this changed the way that people think about investing in this area. But it's a change that has been in motion for a lot longer. The last 25 years has been this increased private sector interest in making money from these diseases, partly driven by technological capabilities, but it very much is brought in bigger companies, as you mentioned. They concentrate on very high profit margins and very heavily used products, or they have a lot of money to put behind changing the market in order to use their products. So global health has largely become like any other industry where you have a manufacturer who's manufacturing something that people may or may not need, but then works on the advertising and tries to convince people that they will need that product, as we saw during COVID. So it's in a way, it's been corrupted by money, but it's the way that we organize companies, and companies are there to make money for their shareholders. And I think that the field has moved generally from trying to do, trying to address high burden diseases and the things that shorten human lives to primarily making a profit for the private sector entities that are involved. And that's a very big shift, but it's why we are where we are today.
Yes, and what we're seeing is the WHO receiving increasing investment from NGOs, the private sector, but that will be earmarked, that will be tagged for specific purposes. These purposes tend to involve either digital surveillance technologies involved in health or in for pharmaceutical trials and testing. Can you talk about how that might alter the capacity of the WHO to act as an independent authority should there be a public health risk?
Yeah, originally the WHO was almost solely run or funded by countries. Now it's 194 member states, although the US is talk of withdrawing. It Most of that money originally was core funding or assessed funding, which means countries give money, the WHO decides on the basis of the policies that are for the World Health Assembly, the countries, and on the basis of its own expertise on what is the highest disease burden, what is the most effective use of the funds, they would decide how to use this money to improve global health. Um, the so that this has changed in two ways. There's been a lot more private sector money come into the WHO from companies and from private individuals. Mr. Gates is an obvious example. And this is now about a quarter of the WHO's total funding. So the other change is with countries as well, and most of their money, along with all this private sector money, is now specified funding, which means that for 75% of the WHO budget, the WHO has to do exactly what the funder says. So they're a gun for hire, or they're almost a public-private partnership where they're taking a lot of public money, a bit of private money, but they're being directed on where to use it. And the countries that have been the biggest funders have been the countries with the very strong pharma sectors. The United States, Germany, which started BioNTech and was a very big funder a few years ago. They technically still are, but they're mostly funding their own WHO biohub within Germany, which is really there to produce, for the benefit of the vaccine industry and the United Kingdom, etc. So it's very, very heavily dominated by specified funding from private public entities that have very strong interest in pharma. So the WHO inevitably has shifted from trying to improve the things that we know make people live longer most effectively, which is better sanitation, better nutrition, etc., to these sort of commodity-based fixes, like vaccines particularly, where a manufacturer makes something for a problem and they use the WHO's influence to make that market as big as possible.
Yes, and if your work is with malaria, it's been with pneumonia, and if then we look at COVID, there is an intersect with all of these diseases where risk centralizes around multimorbidity, poverty, and poor nutrition. And vaccines can't really address that, can they?
They can't. They can help a little bit. But you make a vaccine for a particular disease, they're never harm-free. Any medicine will have some side effects in some people. So, and that varies depending on the person's metabolic state as well. But you can reduce, if there's an outbreak of a certain disease, you could vaccinate people and reduce their chance of dying from that disease. But the main reason they're dying from that disease, whether it's Mpox or COVID or whatever, is because they have a very poor ability to fight that disease anyway. So nearly everyone who died from COVID had severe comorbidities like diabetes, severe obesity, renal failure, which impairs their immune response. And most of them had severe vitamin D deficiency and basic micronutrient deficiency. There's a paper in Nature, the top scientific journal really in the world, pointing out that a third of COVID mortality might have gone away if we just got adequate vitamin D into people. So this is very basic, and if you do this, then not only are they resistant to the particular disease of that outbreak, but all the other diseases that are going to come along the next few years as well. So vaccines have a place, but it is much less important than addressing the underlying problems that make a person likely to die from an infectious disease.
And the new gene edited modified RNA drugs, they're not designed to prevent, excuse me, transmission of infection. They're designed to perhaps stop symptoms in a short space of time. Do you think this makes them suitable for a class of drugs that should be rolled out in a pandemic?
The reason that COVID vaccines didn't stop transmission, it wasn't because they were mRNA based, it was because, or modified RNA based, we should say. It's because they were injected, they're systemic, and SARS-CoV-2 is a respiratory virus that comes through the respiratory tract first. That's where you stop the virus most effectively, in the mucosa of the respiratory tract with a thing called immunoglobulin A. And if you inject someone with a vaccine, it doesn't matter if it's an antigen or modified RNA or whatever, it'll increase immunoglobulin G and M against this, which circulate in your blood, but it doesn't produce the immunity in your mucosa where the virus first infects. So it may stop you dying or make it less likely that you get very severe disease, but it won't stop you from getting infected and transmitting. So, but then, you have to look at what is the risk versus the benefits. And with COVID, we knew that, the average age of death was in Western countries about 80 or over 80, and it was people with severe morbidities. And probably less than 1 in a million healthy children. And we knew that very early on, early 2020.
In the first quarter, yes.
Yeah. So if you had a vaccine like the mRNA vaccine that, in Pfizer's 6-month trial, there was more deaths in the vaccinated group in the vaccinated group than in the control group. So by about 20–30%, the numbers were low, so the statistical significance was unclear, but it was very clear that it wasn't reducing overall mortality in that trial and in the Moderna trial. So it would therefore be sort of illogical to give that vaccine to everyone, including children who are almost no risk, because you've just shown that it's probably, if it is saving people, it's probably also killing people, because you're not having an overall reduction in mortality. So it may be saving some from COVID, but it's causing an increased death probably in another area. So in that case, whether there's an acute outbreak or not, you would only consider using it in people who you thought were at very high risk. And then you would obviously explain to them, it's not helping overall by the look of it, but it may help in you. These are the risks and benefits, make your choice. So that's the way that we've sort of always managed medicines, with a few exceptions that, end up in court for fraud. And it is not at all the way that we manage COVID. We even gave it to pregnant women, even though, and this is the interesting thing about the modified RNA vaccines is that they are a genetic therapeutic, and Moderna class them as genetic therapeutic. It's not, you can argue about whether it's gene therapy or not. It doesn't necessarily change your genes, but there are genetic substances used therapeutically. So there are particular rules on these. Testing for carcinogenicity, does it cause cancer? Teratogenicity, does it cause abnormalities in a fetus, in a baby before it's born? So, but we don't do that for vaccines. So, and it wasn't WHO that did this. It was a national regulatory authorities, which your new legislation is going to say just 2 overseas regulatory authorities is enough. They decided that if you change the name of this genetic therapeutic to a vaccine, then you wouldn't have to worry about cancer or fetal abnormalities anymore, because it's a vaccine, not a genetic therapeutic. And it's just crossing off a bit on a bit of paper and putting a new name. The Therapeutic Drugs Administration, TGA in Australia, pointed this out and admitted they'd done it in their report of Pfizer. So the only data we had on pregnant women, I think it's important to just underline this, was we didn't have any on pregnant women at this stage. We had some animal studies on pregnant rats, and they showed they had a control group and they had a group that they injected with quite a high dose, but with the modified RNA. And in all the categories they looked at, about 13 categories of fetal abnormalities, there is much higher in the vaccinated group, and there is no abnormalities or 1 or 2 only in the control group. So it was very clear, comparing these 2 groups, that there was a huge increase in fetal abnormalities. So what they actually did in that trial, then they said, well, okay, but let's go and look at trials from years ago, and we'll find somewhere the rats had lots of abnormalities. Instead of comparing with the control group that we used in this trial, we'll compare with the historical control group and forget the one that we just used. And they presented that to the FDA, the TGA in Australia, presumably the New Zealand one, the Japanese one, etc., and got it through. So then we had governments and their agencies telling pregnant women to take this, saying it was safe, and the only data they had was it was quite unsafe in pregnant rats. It also had a reduced fetal implantation rate, which means you don't become pregnant as well. And we also knew that in some men it reduced sperm count. So if you had a massive outbreak of a very severe disease, which hasn't happened in modern history, hasn't happened since really maybe the Spanish flu before we had antibiotics, etc. So it probably won't happen again. But if we had that, then you could say, well, maybe we should have a vaccine, vaccinate lots of people, because even if it kills some people, it might save more than it kills. But that you can't say that with COVID. There was never that data. There is never the logic there, cost benefit, to allow what we did to happen. So I mean, this is the worry with the whole legislation that we're talking about, in a way that we've lost our anchor in common sense and ethics and rational thought in global health, particularly in infectious disease in the area of vaccination. And until we regain that, it's reckless to reduce the current barriers that we have against these things.
Absolutely. And we now know, it's quite clear that gain of function underlied much of the development for this. So the concept that we would be developing legislation that would have a mandatory medical authorization in, without actually having already developed legislation that prevents and prohibits gain of function research, is massively problematic. And if we consider the fact that, for example, the German government invested in BioNTech, which was a partner in Pfizer, but the development underneath for the COVID vaccine involved gain of function research. So we see at a very early stage, I think, governments involved in ethically dubious because of the potential for, I guess, this path dependency where they're creating the problem and then the solution.
Yeah, I mean, some people are still trying to claim it's natural origin, but there are no bats. There weren't bats in the wet market apparently, and there's no bats anywhere near that carry this virus. They've never found it in the wild, and the first outbreak reported was just down the road from the only institute in China that was working on this particular virus during gain of function, which was started in North America, shifted across because they thought it was too dangerous in North America, and Obama put a moratorium on it. So just on that, I mean, the odds are obviously on the lab leak. They knew, as it's shown in the House of Representatives report for the US on this release on December the 4th, the COVID subcommittee, that some of the work was being done under BSL-2 conditions, which is very low. And a virus, an airborne virus, will inevitably leak. That there was reports already from the local US consulate there of lax biosecurity at Wuhan. But even elsewhere in the US, there's many leaks from the high biosecurity laboratories. This is an inevitable thing to happen.
We need to actually have understood these background problems, where it can go wrong, before we actually even say, yes, we can have too much biotech development even in laboratories, because the containment failure seen over COVID seems to be a global health issue and a global problem. And you're currently working as co-lead on the University of Leeds REPPARE project on pandemics with Professor Garrett Wallace-Brown. And that's the intent of REPPARE is to facilitate rational and evidence-based approaches to pandemic and outbreak preparedness. And this is involving health community policymakers and the public to make informed assessments. Now, you've released in October 2024 titled When Models and Reality Clash, a review of predictions of epidemic and pandemic mortality. Now, this was submitted to the New Zealand Commission, COVID-19 Lessons Learned. In New Zealand, our own modelling during the pandemic occurred under the auspices of the Department of Prime Minister and Cabinet. It did not evolve with a bunch of public health epidemiologists looking at the modelling and the data. It evolved with statisticians, physics and maths experts. So there was no public health ethics built into that. So it didn't really take into account age stratified risk, and it wasn't able to precautionally look at the problems that could arise. Can you talk to me about what the REPPARE report in October has found?
Yeah, I think it's an important report. It looks at the work of Ginkgo Bioworks, which is a company that took over a company called Metabiota that did the original modeling. Then the reports from Ginkgo. It's a US company, and they're used by the World Bank, WHO, etc., governments. So this report, it was used at the New Zealand Royal Commission. It's also used by the Lancet Commission on health financing for all their pandemic predictions, etc. And it comes up with 2.5 million people on average dying every year from acute pandemics. And therefore, it's a huge problem, twice as big as tuberculosis. Of course, we should do something about it quickly. Now, COVID, according to the WHO, killed about 7.5 million people, the virus. So that's 3 years of this, but they're saying this is every year. So for the last 100 years. So what happened in all of those other years that we didn't notice 2.5 million people dying? And they show this, how they did the modeling. And this is modeling, it's not common sense. So they went back several hundred years. They have essentially medieval outbreaks, such as the Black Death that killed a third of Europe. And they used that to extrapolate to today's population, and that's a lot of people, and say, well, if the Black Death happened now, this is the sort of thing we see. So they're ignoring the fact that they haven't had an outbreak like this of any sort, since even the Spanish flu was tiny compared to the Black Death, and that was over 100 years ago. And then you go, there's some typhus outbreaks and cholera and so on, but nothing like that. So it's like using something from Mars and saying this is what will happen on Earth. And we know it won't, because we know that now we have much better sanitation. We understand about germs and how people get sick. It's not vapors in the air. And we have better nutrition, we have better living conditions, all the things that stop you from dying from infectious diseases. So it is, you would think someone would pick this up. Because if you look at the actual deaths from outbreak and you take COVID out, you look at, say, what the G20 came up with for the 20 years before COVID, for major outbreaks in their report that they produced in 2022 to back the WHO's pandemic agenda, that they come up with, it's about 160,000 deaths, I think, in 20 years. And most of that is swine flu in 2009, which killed less than normal flu. The next one's a West Africa Ebola outbreak. The next one is 11,000 dead or 9,000 dead from the cholera outbreak that the UN caused in Haiti. And then there's nothing. And if you look at the WHO's own list of high priority pathogens for their research and development, it's the same. Almost all on the list have never caused 1,000 deaths in the whole of human history. So you suddenly go from reality, which is that almost a tiny number of people die from these natural spillover diseases, to 2.5 million people, because we think the Black Death is going to happen again. And only a modeler really could think that, because you would have to not understand the relationship between pathogens and humans. And you would not have to be aware of the history of infectious diseases and the current trajectory. Basing these decisions on this just quite insane approach to disease.
And not incorporating in there the risk from, you have the respiratory virus, but then you have the lower respiratory tract infection from bacteria, which is pneumonia, which is what kills people. And that's what we can now stop with antibiotics, antivirals.
Yes, almost always, yes.
And this link and this connection really wasn't discussed during COVID.
No, it wasn't. And most people who died from Spanish flu probably died from secondary bacterial infections. Anthony Fauci wrote a paper on this.
And what is quite alarming is that metabiota paper that you study in your October 2024 paper, that was one of the two main sources for concluding a rapidly rising risk in the G20 high-level independent panel, the HLIP report in June 2021. This is alarming.
It is alarming because and the other list they had in that, the other source in that G20 it's called Annex D. It's just a list of, it's what I mentioned, the major outbreaks of the last 20 years. And, you take out swine flu, which is less bad than usual flu, and there's nothing left. So yet in the text, they're saying there's an existential risk, and we have to act quickly. We have to devote tens of billions of dollars a year to this. So politicians, they haven't got time to sort of look at all these graphs and think through the numbers and check against history and check again, etc. They assume that the G20 high-level independent panel is high-level and independent. And they assume that the World Bank is a reliable source. They assume that WHO is a reliable source. The WHO has they put out a report with the World Bank on financing, which we go into in another repair report. And they rely very heavily on a chart in it. And it has over the last few decades, and it's got the cost of outbreaks, which enormous on this graph, and it's got $9 trillion for COVID. And then it's got a line at the bottom, the costs of TB, HIV, and malaria at $22 billion a year. Now, in 2018, the Lancet had a study published, which the WHO at the time, I'm sure, would have agreed with. Tuberculosis alone was about $580 billion a year. So, and add malaria to that, add HIV to that. So in this graph, the WHO are essentially lying. They are deliberately misrepresenting the truth. They're massively reducing the cost of normal diseases, and they're massively inflating the cost of outbreaks. Because if COVID costs $9 trillion, it is because it's not because it was killing people at an average age of 82 or 3. It's because, and 0.3% of the population or something, it's because they stopped supply lines, they stopped travel, they threw hundreds of millions of people out of work, they stopped education, etc. They closed down markets, they did all the things that we know destroy economies. So of course it's expensive, but that's because you choose to do that for a virus that clearly doesn't warrant it. So then you produce that and you say, well, if we put in $30 billion a year, we'll get a 200 times return on investment. Whereas we'd never get that from TB, malaria, HIV. But this is on completely false accounting. But as a politician, you assume that the WHO and the World Bank are reliable. So I think most politicians involved in this are acting in good faith because they haven't grasped the takeover of these institutions and this whole industry over the last 20 or 30 years. If you're a person like myself, but you're younger and you're trying to start a career, and you start talking about, the truth of pandemic risk and the fact that actually very few people die of pandemics compared to other diseases, and that the best way to improve resilience against infectious disease, including pandemics, is to improve nutrition, living conditions, so sanitation, which is what I was taught in medical school. It's not some conspiracy, it's the fact, and all the data shows this. If you start saying that, rather than going into the pandemic sort of jobs that are there, then you won't have a career. Maybe you get a career in climate and health because that's another way down this path, but it's very difficult for the people in the field now to stand up and say anything. They have kids in school, they have pensions to worry about and houses to pay off. So they need an income. So this all influence. There are thousands of people now doing surveillance for viruses that might become pathogens. So we keep hearing about, they find some genome of bird flu in milk somewhere or whatever. I mean, it's always been there. That's nature. But if you look really hard and you pay lots of people to find it, firstly, the people will do it because they're paid to do it and they'll do what they're paid for because they're human. And secondly, they will find it, and then you can use that to create this fear. So this affects politicians as well, and the whole industry now is really being taken over by this sort of pandemic industrial complex. And it's a good term because, the military industrial complex that Eisenhower talked about and so on, it's exactly the same incentives, exactly the same way of working.
And you've got COVAX, you've got the big NGOs that are also investing in, they're not just simply donating, they're actually investing in the developers, and they're making money, buying and selling shares. So we can be really skeptical. And so you were talking about how the scientists have to follow the money. The public health doctors have to follow the money. This is the same problem in New Zealand. My master's looked at the challenge that scientists have in sourcing income, looking at getting funding for research projects concerning endocrine hormone disruption, whether it's cancer or neurodevelopmental toxicity or whatever. They cannot get the funding unless they're building in innovation, which is of course a proxy term for IP or royalties and patents.
Yes.
And so the New Zealand's Attorney General, who's also in the GCSB, working with Five Eyes on intelligence and defence, has just created a science policy process where you're going to see a reinvestment, a reinvigoration of investment in space, but also biotechnology. And I would argue that she's hoping that New Zealand will become a whale, will become one of those big, massive success stories for biotechnology. But the requirement to invest sufficient money in biotechnology for it to actually give a return, to me, that seems like a real distortion, because New Zealand's got one of the highest obesity rates in the OECD. We've got high cancer rates. We've got other, associated, illnesses that are connected to metabolic syndrome. But that money, that investment in research and care, is being diverted into biotechnology. Do you think is this being replicated in other countries, or is it just New Zealand?
No, it is. It's everywhere, which is one of the reasons why New Zealand probably won't make much money out of it, because everyone else is doing it and they're bigger. But yeah, it's because you can make money from this. People are seeing people making money from this, and you don't make money from improving sanitation, improving nutrition. And
well, short-term money, I guess.
Short-term money, and that's all that matters. You're not, if you're about getting IP, you can't get IP by improving vitamin A levels in children. I mean, you don't get a long-term income from that. You just make them less likely to die of all sorts of infectious diseases. But if you come up with, a new gene editing tool or a new diagnostic or something, then it may or may not be useful, but you can patent that. You can tick that box. And there's a potential income stream in the future specifically from that. So the whole population will gain from better nutrition, but that's not what you're after. You're after an income stream for your research group in your university. That's the only metric that they're looking at.
Yeah, and the gene editing bill is presuming that in the secondary legislation, this is of course would become primary legislation, that there will be all the regulations to assure safety. So we didn't see those cancer, the requirements for mutagenicity or cancer tests when it came to the biologic product for humans. But we're also, the New Zealand government is a half owner and investor in a startup, a biotechnology startup that's also looking at methane drugs for livestock. So if you think about what happens to mammals when the microbiome is disrupted, there's no discussion in New Zealand about the potential impact on fertility, on growth, reproduction rates. In any of their discussions, they're simply presuming that they'll put a methane drug that will impact the gastrointestinal impact of, sheep or cattle, and that's all. So can you envisage these problems not just for biotechnology outcomes in humans, but in our livestock and agriculture?
Yeah, I mean, it's the same as long as you can sort of mandate it, which will be pretty easy with this. You will say that methane is a existential danger to the environment, and therefore you can't run cows unless you give them this drug. Then it doesn't matter if it's right or wrong, you have created a market for someone to get rich on, and they will drive that market and get rich. And so this is a problem also with governments getting involved, because then, maybe some information will come along saying, well, actually, methane's not anything like the driver of global warming that we thought. But there's a sort of sunk cost in this, opportunity cost and sunk cost, and it'll be very hard to undo these things because people who are influential are making money from them. So it sort of colors the whole need. So I mean, it's exactly what we see in the human health, in that we are essentially inventing this risk of pandemics. It's not completely invented, but the risk is the size of the risk. And we're doing that because, simply because there's money in it in the end.
Yes. And the perverse, it's really interesting because you're talking about the money that the government can make. The joint ventures shareholders for this methane and other technology project are Fonterra, the big milk company, Ansco Foods, Rabobank, Ravensdown, Silverfern Farms, Synlait, and as well as at the Ministry for Primary Industries. So these are almost monopoly type firms, or duopoly type firms in New Zealand. They exert enormous power. So the concept that the people supplying the meat and milk and fibre to these firms would then be able to turn around and say, well, we're not going to buy from you if you don't take that drug. You get this massive ethical kind of screw up where these firms are essentially profiting from that product, but they're demanding that the farmers inject or accept that product for their livestock. And that no one in New Zealand is talking about that.
No, I agree. There's all sorts of ethical holes in this. So yeah, I mean, it is not that different from saying, you look at the FDA. I think it's 11 of the 12 largest commissioners have gone and worked for pharma. It's the same sort of thing there. So the government should be sort of step back and just taking the public side in this. But as soon as they get into the industry itself, then they have this conflict of interest.
Yeah, so in New Zealand, the Ministry for Business, Innovation and Employment has pulled together, working with Crown Law and the Attorney General, Judith Collins, this gene technology bill. So the Ministry for Business and Innovation is developing the regulations for legislation that should steward a technology in human health and in the environment. And so they're pulling out the precautionary principle, which is in the Hazardous Substances Act, and they're putting in must-have regard for the provisions of the Convention on Biological Diversity and Cartagena Protocol. But having regard for in law does not place an obligation on officials to take the matter into account. So we see them subverting bioethics. The Royal Commission 20 years ago in New Zealand said we need a bioethics task force. That's never happened. In COVID, we didn't have a bioethics task force. And now they've pushed ethics aside. Yet everything we've been talking about today, and people might be sick of people talking about COVID, involves navigating social, cultural, political, economic, financial, all these things that are very human. So this is why, can you talk about public health and ethics just for a little bit, please?
It's a broad subject. I think this change all became more codified after World War II for obvious reasons of what happened with the medico-fascism, etc. But that wasn't just Germany. It was the same thing was happening in the United States with the technocracy movement and with forced vaccination and sterilization, etc. Rather, forced sterilization of people who were considered less fit to be reproductive humans by people who decided that they could take that role. So it's all based on informed consent, which means that you can, or bodily autonomy. So you cannot force something on anyone. And you have to give them all the information, both sides of the equation, so that they can make an informed choice. And this is the very basis of medical ethics. So that, I mean, clearly that didn't happen in COVID. And that what COVID showed us is how easy it is to completely upend what we thought was medical ethics. I mean, we should have known because Germany was leading medical ethics in the 1920s, and then the German health profession was they had more representatives in the SS than any other profession. So they were very keen on, by and large, on fascism after they excluded their, I think, 40% Jewish ethnicities. So it's very easy, and there's a long history of public health going down this road. So the idea of post-World War II ethics was really to stop doctors from abusing patients and abusing the population, and that's what the Nuremberg Code was about. It's what the Helsinki declarations and so on around research ethics, and the declarations on informed consent is what the Universal Declaration of Human Rights is about. So rather than follow that path in COVID, we decided we will go back to the 1920s, 30s technocracy idea that there are experts and they will tell everyone else what to do. And because they're experts, everyone else must follow. So it's exactly what happened with the eugenics movement, is exactly what happened in the technocracy movement, which is, 500,000 people in North America.
It's very uncomfortable to talk about this too.
Well, it is, but we have to, and we shouldn't be that surprised. What happened in Europe in the 1930s and 40s was done by the people who lived in Europe in the 1910s and 20s. It wasn't different people. They're people like us. And this was not just Europe, this was North America. I mean, if you look at what, I'm Australian, the history of how Australians, the European Australians treated the native population. You can see that people who appear normal and decent and civilized can do really horrible things really quickly. And that's why we have these inviolable rules of ethics. And we decided in COVID that because we convinced ourselves, or someone decided to convince us, people, that it was such a threat, such an emergency, even though the average age of death was over 80, that we had to throw away all these ethics and go back to experts telling everyone else what to do. And, the whole point of ethics is that you can never do that. The whole point of ethics is that there are inviolable rules on the way humans interact with each other. But it is that easy for us to decide to go against this. So this comes, this is why we need these firewalls between government and between industry. It's why we need firewalls between WHO and the private sector. We always think we can handle this, but history tells us that we never can.
And what we're also seeing, I'm not sure whether this was happening in the 30s and 40s, but we're seeing NGOs or industry associations as NGOs effectively policy laundering on behalf of the private sector. And so they're able to policy launder into the governments to get the funding and then go back to the WHO. So they're marketed as legitimate by governments, by media, but they're actually they're sort of gophers between their enabling devices, but they're not taking into account ethics. They're not obligated to think like that. They're just doing business deals. This is
Yeah, and the
breakdown.
big public-private partnerships internationally, so Gavi, CEPI, and so on, that are running the vaccine agenda and the pandemic innovation agenda. They have private people on the board. They use public money mostly, but they also have private money, and they have private people on the board deciding how to use public money. And they, like those that fund the WHO directly, they can only do this if it is good for their investors, if they will get money out of it. And their job is not to do a global good that will happen to help their investors. Their job is to maximize return on investment for their shareholders. And so they must steer the agenda to maximize their own profit, not to help populations. This is their job. And, we seem to have completely forgotten this. When the government's working with private industry, the private industry is not the partner because they want to help the people. The private industry is the private industry trying to make as much profit as possible. Yeah. And that's not a bad thing. But as long as there is an ethical code and a completely independent regulator, etc., that oversees all this, and that's what we've thrown out the window.
Yes, and your point about firewalls are so important, and the government is in place to provide for the basic infrastructure services that work better if we're all sharing them: roads, hospitals, education, so on. But governments are also in place to prevent the abuse of power. So when we start seeing these international contracts being signed for these biotechnologies that are not that have commercial in confidence arrangements around them, this is a breaking down of government, because I can't do an Official Information Act request to understand what was in the contract, what were in the conditions. So we can't go producing gene editing legislation when we have these, we have demonstrated failure where New Zealanders still haven't seen the contract that was signed with Pfizer. And so
it's quite incredible that Australians are the same thing. Most countries, I mean, this is public money. This is your money, yeah? That your elected representatives, who are supposed to be only looking after your interests, did a contract, and they won't tell you what is in the contract. It's just like it defies common sense.
Absolutely.
And all they're doing is buying a product. They're not inventing a vaccine that is going to have some IP, blah, blah, blah. They're buying a product from a company that's manufacturing it. That's all they're doing.
Do you have, I'm going to finish up now. Do you have any further thoughts that would be of use to members of parliament that might be listening, or even just ordinary society?
Just that we are not in an existential crisis. We're not all about to die. Things are actually getting better, and the numbers show that less people are dying of infectious disease, less people are dying from outbreaks. We're getting much better at detecting outbreaks, but less people are dying. So, from natural outbreaks, not from man-made ones. So we are not in a desperately urgent situation to do all this. Yeah, the common sense is a very important feature of the way that humans interact with each other, and transparency is important, and it's essential in a democracy. So, we seem to have got ourselves into a bit of a lather that we have to do this really quickly, otherwise we were going to die of the next outbreak. I mean, this is a marketing strategy. It's not real life.
Yeah, and so, and New Zealand's gene technology bill, we can PSGR are going to be recommending that we discard it, we put it on pause, we forget about it, but we can adapt the Hazardous Substance and New Organisms Act 1996 to include a more accurate tiered process of assessment. We keep the ethics considerations in, which is in the early sections, including the precautionary principle. There is no need to spend all the money on this gene technology bill when we can see in the underlying issues that concern public health, that the issues regarding public health and the need for biotechnology kind of get wiped away when we start thinking about what is really required to help to protect health. So what we've seen also is a sort of last comment. We saw, I think, an Oracle founder discussing the fact that new cancer drugs, biologic gene editing technologies will be used in the new cancer drugs. But 20 years ago, with the Genome-Wide Association studies, the GWES for the Genome Project, they recognized that perhaps over 80%, even 90% of the chronic illnesses we're seeing in society are driven not by genes, but by environment. And often there are many traits we see in an organism, but many, many, many genes, even hundreds of genes, will go towards that. So do you feel that the impact from biotechnology in being able to support human health and thriving and planetary thriving is under or overstated?
I think it's massively overstated. The cancer's a good example. So they think they'll use AI to find the key genes, etc., etc. But as you said, there is very extensive studies, and we thought 30, 40 years ago this would be the key to curing cancer. Then we discovered that actually cancers have a huge range of genetic mutations underlying them. And there are a few genes that make certain cancers more common, but it is a very complex, heterogeneous situation. And that's probably because the underlying cause is more related to a failure of gene repair and DNA repair. So, which is, the metabolic theory of cancer, but it's been around for 100 years, but it's very hard to make money out of getting people to eat better. It's the same as the infectious disease story. You're highly unlikely to die of infectious disease if you have a strong immune system, which means you have very good nutrition and exercise and low stress, etc. We know this, we've always known this, is what science has shown. But you don't make money out of that. You make money out of the vaccine. So with cancer, it's the same. You make money out of poisoning cells or gene therapy or whatever. It doesn't mean they won't help some people. And the idea of tailoring treatment to a particular cancer is a very exciting and interesting one. But it's like an infectious disease. If you can, you're probably going to get far more benefit overall by improving the determinants of whether you get cancer or not in the first place, which means helping people to get healthier, less fat, etc. And so that is where you would put your money as a government, because you'll get the greater benefit. It doesn't mean people won't be helped by these other therapies, they will. But at a population level, you're much better off going for the basic determinants of health.
Absolutely.
But that is not where you make a lot of money. It's not where you get IP.
Yeah.
So we designed a system where that doesn't count.
And the government's not factoring into account what drives productivity, what is also driving our high disability rates. And
Yes.
you start looking at really simple nutrition, basically what our ancestors ate 30 plus years ago.
Yeah.
And then you start looking at, okay, are we getting enough vitamin D? And that's really simple stuff that can be put. It's actually extraordinarily exciting. And the concept that poor nutrition drives not just respiratory infection, pneumonia, but it drives the metabolic suite of diseases, including cancer, and it drives mental illness. I mean, we can really do an amazing work in public health. And I think it's about people like you standing up and talking to the hypocrisy, the irony, and the actual sort of the fraud and corruption that we're seeing. And we have to label it fraud and corruption, and then say, hey, we've seen that. We can turn to something that's way better for human thriving.
Yeah, the World Health Organization defines health as physical, mental, and social well-being, not just the absence of disease, or in this, the absence of a virus. So, that was thrown away in COVID. There is no mental and social well-being went out the window, but they're equal in the definition of health. So you're right. I mean, if we go back to that, people will live longer. Actually, we know that because that's why people live longer.
David Bell, thank you very much for your time today.
Thanks, Jodie.